let's see here. Who do I want to pick on today? Let's see. I've picked on big government, big pharma, big pharma again, big pharma again, big pharma again. Let's see. Who do I think bears a lot of the responsibility as I've dug into our healthcare, or as I like to call it now, our sick care system, because that's what it is. Who do I think bears a lot of the responsibility, arguably the majority of the responsibility for how broken it is? Big insurance. Ding, 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 ding. And I'm still going to pick on Big Pharma a little bit through the lens of a little case study, just to go in the Wayback Machine to, I don't know, 20 years ago, and the opioid epidemic. And I'm going to talk about how insurance was in cahoots with Big Pharma throughout that process. And really how this system, so really in my mind, the three big bad wolves are big medical, big pharma, big insurance. Hang in there for my disclaimers. Do I think that those industries are inherently bad? Kind of. Do I think the people in those industries are? No, I do not. I would argue that the majority, over 90% at least, I'm sure there are some bad actors. There are in every aspect of life. I've met pharmaceutical sales reps. I've met medical device sales reps. I've met people who work for big insurance companies. I've met insurance salespeople. I've met physicians. We've all met them. And I would say that I can't think of anybody, granted, I didn't know some of them very well, but I don't think that I know any that I would say are bad people. I would, in fact, say that they're well-intended, that they're smart, that they keep themselves as abreast of knowledge as they possibly can, given their, their specialization and the nature of their work that they do specifically. I think the systems at large, and you be the judge. I'm going to just pull back the curtain and tell you what I've learned about how big insurance actually operates and what the results that it's actually yielding after it ping pongs around, this pinball machine of a system. How that translates then to us as end patients, our children as end patients. And I'll let you be the judge, because I know that a lot of you, big insurance, and if you're like me a year ago, I would have gone, what? Like, we want health insurance. We need health insurance. Like, pretty much can't survive without health insurance. We'll go bankrupt if we don't have health insurance, right? I'm not telling anybody to go out and cancel your health insurance plan, please, for the love of God. I'm going to talk about these systems and why I think big insurance is arguably the most culpable of them all, and why that is. But the people, listen, I grew up with, my mom is a registered nurse, has been my entire life. Since I was, a little baby, I was sitting on the floor while she was studying for nursing school. So, and my dad, growing up, when I was little, he worked for a big hospital system in the area I grew up in. And I met a lot of the people, but I was raised, in, as many of us are in this country, that you trust your medical providers almost without question. If you have a little gut inkling that something is off, or I don't know if I want to go on that drug, or I feel like we should be testing something else, or I feel like the regular blood panel won't cut it, zip your lips, fold your hands, smile, sit there like a good girl, and listen and do what you're told. We're taught to be compliant because we're taught, you can't be trusted. You did not go to med school. You do not know how these things work. It's way above your head. So as a patient, we have been taught systematically to ignore our gut. And I saw this at its most rampant probably when I became pregnant and when I had kids. That's when I saw it, mostly from, and I loved my OBGYN. He is such a good person. I would vouch for him in a heartbeat. We chose to have both of our babies with him, really enjoyed my appointments with him, trusted him. I still trust him to an extent now, knowing what I know about what gets filtered out and just the shenanigans that happen before any information ever gets to a physician, and then what the kind of hand of cards that they're dealt with which to make their decisions in their practice. Now that I understand that, I would take it with a grain of salt, and I would ask questions if I, were pregnant again. I would push back if I were pregnant again. And I think just talk to moms, even moms who totally buy into the healthcare system and do everything they're told, like I did. And usually you'll get some kind of story about, at the very least, medical pressuring, at most, like just flat out medical bullying and gaslighting. It happens all the time. Like, just go have a baby in a hospital. Like, and listen, I know moms who they would never have a hospital birth, if their life depended on it. Not to use like a totally the wrong pun there, but legitimately like would refuse to have a hospital birth unless they absolutely had to. And I can see why. I believe personally that, we're in this modern age of some of the coolest medical advancements in the history of mankind. We should be able to take advantage of that and have this safety net of a hospital without all of the strings that come attached. And if you've had a hospital birth, you probably know, or at least had some inklings of what I'm talking about. Like, we magically have to stay there 48 hours because, imagine that insurance covers, 48 hours of your stay. So they got to squeeze all the profit they can out of you because, spoiler alert, this industry is about quarterly earnings. And you can check every data point I'm going to give you against that. But when that's not a bad thing. It's not a bad thing that, these companies these systems are out to make profit. That is their primary concern, not the people who work in them. Their primary concern might be helping people and doing what's right by people. But when they're operating within a system whose one and only true north is quarterly earnings, some bad outcomes are going to happen and some shady things are bound to happen and are happening all over the place in our sick care system. It's a sick care system. It's not a healthcare system. And I'm going to do just a little reality check here in a second, just to talk about outcomes in the U.S. as compared to other developed countries. And you can see just how poorly we're performing in the U.S. And that's just compared to, other alike nations, other developed countries. But, in the hospital, how they knock on your door after you have a baby, like every 20 minutes, when you intuitively know, like, I'm pretty sure the thing that I need right now is sleep. Like, I don't know why you have to weigh my baby again for the 15th time today. Because every time they come in the room and knock on the door, it's a little bit more money. Got it. But just, it started to just be brought a little bit more to my awareness. And as I've kind of gone on this journey simultaneously of learning more about these things, but also trusting my gut and getting in touch with, my gut in the first place, for the first time in my life, like I never, ever, like, I would almost be sheepish to it. I almost feel sheepish now admitting, like, I kind of trust my intuition now. Because we're not taught to do that. We're taught, in fact, like, you're a woo-woo conspiracy theorist, like, natural, water birth having, like, off your rocker mom. And I know a lot of those moms, and I'm pretty sure the ones that I know would stand by that and be like, look at my 7 healthy, thriving children and tell me I made a wrong decision. Go ahead. Tell me which decision I made was wrong. I'll wait. So like, I completely agree with that, mentality. I also think that, like I said before, we should be able to have the benefits and be able to reap the rewards of these thought leaders in the scientific and medical spaces without having the strings attached, without having to ignore our guts and not ask questions. And so that's going to be the ultimate gist of this episode, is like, ask questions, do your own research, follow your gut. And ultimately, it's your health. It's your health. It's your life. It's not that doctor's sitting across the room from you. It's certainly not your insurance companies pushing those papers at you, telling you what's approved and what's not. And I can't solve a lot of these problems that I'm going to walk through today. All I can tell you is do as much research as you can. Be as informed as you possibly can when you're making these decisions. Sometimes all of your decisions that are going to be at your disposal, given your financial means, are going to be less than ideal. Unfortunately, until we remedy these problems, until we make the system better for us and more accessible for us to all have the highest quality care we can. And I'm getting off on a tangent. But until any of that happens, we've got to do the best with what we have. And we have a broken system. And I'm really sorry about that. And I'm really sorry that I'm going to deliver a lot of bad news today. But it's broken. And where the empowerment comes in knowing it's broken is knowing that it is okay to go with your gut and to do your research and to ask around and to get creative. There's a way to operate within this system and navigate it once your eye opens to some of these issues. Once you know where the pitfalls are and where the problems are, you can better navigate that system and squeeze a little bit more out of it than you can blindly walking in blind faith to these systems that do not have our best interest at heart. I'm sorry, they have the best profit at heart. So just a quick reality check. How are we doing in the US then? If we're the most, because in my mind, my perception has always been we are the most medically advanced country. We are the most advanced country in the world, right? We're so lucky to live here in the US. I still believe we're so lucky to live here in the US, but our outcomes are pretty piss poor. US maternal death rate is higher than any other developed country and has been rising since 2000. And I'm going to link to all of these sources in the show notes. These are open secrets. These are not secrets at all. You might not have heard them. They might not get a lot of play, but they're not secrets. Coffee. Okay. Same with the infant mortality rate in the US, higher than any other developed nation in the world. In fact, our infant mortality rate here is 71% higher than the comparable country average. That's high. Among the 5 leading causes of death in the US, so like heart disease, stroke, respiratory disease, those sorts of things, an estimated 20 to 40% of those deaths are preventable. The US spends more on healthcare as a share of the economy, nearly twice as much as the average OECD, no idea what that means, just look it up, country. Yet we have the lowest life expectancy and the highest suicide rates among those 11 nations. The US has the highest chronic disease burden and an obesity rate that is 2 times higher than the OECD average. Americans had fewer physician visits than peers, which may be related to a low supply of physicians in the US. We'll come back to that. Americans, this is lastly, just in terms of just flat out results, how are we doing in our healthcare system? Americans use expensive technologies such as MRIs and specialized procedures such as hip replacements more often than our peers. And there are all kinds of stats about how many more surgeries we tend to do. Your hip surgery. Regardless of the fact that there are tons of white papers and research done around these more emergent technologies that are much more effective at, spine surgery, hip replacement, like we're just going to, do surgery. So based on that alone, like my first question before you just move on with me is to ask yourself, do you think we're doing great in this country? Or do you think there might be room for improvement? Is it because we don't have, great med schools and great medical professionals? I don't think it's for lack of great people and smart people. I don't think it's because we don't have enough brilliant, caring people in this country. I think it's something to do with the system. So let's dive right into a few things to know about big insurance. So we know big insurance, they control which drugs get approved, which go on the formulary, so which ones are going to be covered and to what degree. They determine what your copay is, what your employer's expenses are. If you're an employer and you offer insurance, most people are insured through their employers. They also decide what tests and labs and treatments are reimbursed and which are not. And again, it's all about quarterly earnings to these insurance companies. So we have this idea, preventive care is covered. Preventive care. Less than 2% of an insurance company spend is on preventive care. Just let that sink in for a second. Less than 2% of their spend is on preventive care. Why is that? Well, when you look at how the model is set up for insurance companies, it is just more beneficial for them to kick the can down the road. So the average employee changes jobs every 2.5 years. So even though, let's say somebody's pre-diabetic today, why would I pay for tests and treatments that are going to prevent them from becoming a diabetic when we know that once they move into actual diabetes, the cost is going to be 7-fold per year for that same client? Why? Because that insurance company is playing this shell game. They're gambling. They know that that employee is most likely going to switch jobs in the next 2.5 years if they just got on this plan. We're just going to kick the can down the road. They're not going to get to full-on diabetes tomorrow, chances are. Therefore, we're not going to pay for this preventive care. We're not going to, fork more money out to help this patient right now. We're going to make it somebody else's problem. So that alone is just one example, one of a jillion examples of why preventive care, why things that have been tested, have been proven. Like thought leaders are really pushing that you can only find nowadays, if you do research and find a cash pay model. I used to have this perception, just as an aside, that, cash pay, like private pay physicians, like they must like either be lazy, they just don't want to deal with like billing insurance, or they just don't care about, people's finances and about, lower income patients. Nothing could be further from the truth. They just want to practice good medicine. Like they just want to ultimately do what's right by their patient. And that is almost impossible to do in an insurance model. It is. It's almost impossible to do, especially depending on your specialization. Mental health care, it's hard. Primary care, it's hard. So additionally, so it's just not worth it for doctors to fight that. So you would think, like, I would tend to reason, okay, if insurance companies aren't going to cover that, my doctor cares about me. My doctor's going to fight it. And if he or she knows of a treatment that's going to help, or a test that we need to run that's going to help, they're going to fight for it. So it's not worth it, because first of all, if they know that those tests and treatments won't get approved, even if they do push it through, what happens, if you talk to people in this industry, what happens is they end up getting warning letters from that insurance company. Like, if you don't stop trying to bill for this test or bill for this treatment, they'll accuse them of, like, you're just quote unquote driving up the cost of healthcare. Stop billing this, stop recommending this to patients, or we'll put your contract under review. And if I'm a physician and I lose, Blue Cross Blue Shield as an insurance contract, I'm screwed. Like, because there goes all my Blue Cross Blue Shield clients. Like, they need these insurance contracts to get business. So they're not going to fight it for the most part. One little example is genetic testing, and I forget the exact name for it, but it's the little cheek swab. I heard of it back a couple years ago. It sounded incredible to me at the time. It is incredible. It's a cheek swab that tells you how well you're going to metabolize a whole array of drugs. And this is important because drugs, especially high-risk drugs like Plavix, for example, it can kill you if you metabolize it too slowly. So they can run these cheek swabs. They can tell you, a small percentage of the population cannot metabolize opioids, so they don't get pain relief if they take opioids, no matter how much they take. They could be, before you prescribe these potentially hazardous drugs, let's do a quick cheek swab and test how well your patient's going to metabolize that drug. Insurance covered it for a few months and then stopped covering it, told doctors, like, stop doing it. We're not going to pay for it. When, like, you would argue that pretty much makes sense. Like, this is the difference between, prescribing somebody opioids or not. This is the difference between prescribing somebody a high-risk medication and not. This is, versus finding something else that they're going to metabolize. Okay. And then you have a patient you prescribed opioids who comes in, and are they drug seeking or are they just still in pain? You don't know, because you didn't run that cheek swab. On that note, over the next decade, what we're facing in this country is about a 40% reduction in primary care physicians, because this industry has become just too impossible for them to make a profit and to do a good job. They get minimal reimbursement. So primary care physicians, they have to see an average of they spend an average, of 7 minutes per patient. 7 minutes. That's why I just talked to a physical therapist, so not a primary care physician, but I talked to a physical therapist recently. And she's like, I'm cash pay because I can't do physical therapy in 12 minutes. Like, I would have, it was something like 7 to 12 minutes, something like that. I would have a few minutes to see a patient for physical therapy. No, I need an hour with them. So in order to spend an hour with a patient and actually do proper physical therapy with a patient, I have to just move to a cash pay model and circumvent the insurance system entirely. And a lot more providers are, I've noticed, at least here in Nashville, like, are starting to do that. You're starting to see more regenerative medicine, more functional medicine, more cash pay mental health providers, cash pay physical therapists, even primary therapists. A lot are moving to this model, which I think is great in the sense that we can actually get good care. Where it becomes, a challenge that we have to figure out as a society is how our lower income people who can't afford to pay out of pocket, how are we going to give them access to the same level of care? I have to take lots of drinks because my throat is getting dry from all of the talking I'm doing at myself. Okay. So what do these doctors do? So doctors are getting out of the primary care business. Long story short, it's just such a grind. Um, yeah, an average of 7 minutes per patient because they have to see enough patients to meet their overhead. They end up, in a lot of cases, ending up owning into MRI companies, pharmacies, businesses like that, which is legal if you do it in a certain way. Like, they're not supposed to get kickbacks. A lot of them do get kickbacks. There's a lot of shady practices with that. But a lot of doctors, if they, refer you to get an MRI, depending on what field they're in, they might own part, they might have a part ownership in that MRI company, which I'm not saying is a bad thing, but I'm saying these are things that over time doctors have started looking into more and more so that they can continue to make money because the insurance system, even though the cost of healthcare for end consumers is going up and up and up, doctors are getting minimally reimbursed. So this is something I had never heard of before, didn't know existed. It's a real thing. It's a big thing. It's called PBMs, Pharmacy Benefit Managers. If you've heard of them already, congratulations. You're a very smart person. Their role is to negotiate drug prices between drug companies, insurance companies, and pharmacies. Sounds like a good thing, and it was initially back in the 70s when pharmacy benefit managers were like invented as a thing. Said, hey, they're going to negotiate these prices to help keep drug costs low. And it worked for a while. Well, then they started introducing rebates. They started building in rebates to the model. So if I negotiate these prices for you, if I get your drug, pharmaceutical company A, on this insurance plan's tier 1 list, this is the rebate that you have to give me when somebody buys the drug at a pharmacy. So what that did is it indirectly started driving up the costs of drugs in the US. Because pharmaceutical companies, they want to get on a higher tier, right? So that it's covered and therefore prescribed more and therefore they make more profit. So they agreed to, a certain rebate. Well, then what do they end up doing when they're making less off of that drug because they're giving a rebate to the PBM? Well, they just increase the cost of the drug. That's just naturally, it's economics 101, and that's what's happened. Supply and demand. Over 82% of the prescriptions filled in America are controlled by the top 3 PBMs. 3 PBMs control 82%. Guess who owns the pharmacy benefit managers? Guess who owns the PBMs? The big insurance companies, Aetna, Cigna, United, they own the PBMs. So it is companies who are getting rebates and working on behalf of big insurance. So it's yet another example of this incestuous healthcare system where companies are regulating themselves and they have an interest in the companies who are supposed to be regulating them, and then they pay the FDA to regulate them, and then after the FDA director regulates them, then they go to work for them, and it's so incestuous. It's ridiculous. But what's crazy, I thought was really crazy, just at a very practical level about the way these pharmacy benefit managers and their rebates work. So I might go to the pharmacy to fill a prescription. Let's say that prescription costs $2. Like the true cost of that prescription is $2. So the pharmacist might charge me $5, so that they make a markup. If they see at the pharmacy that I have insurance, or if I show them an insurance card or it's just on file, they are immediately under a gag order. They cannot tell me what the real price of that prescription is. Instead, they have to quote me. They say your copay is $30. My copay is $30. I pay $30, and then they have to give a kickback of, $25 to the PBM, let's just say in that scenario. So there are cases all the time where somebody goes to fill a drug, and let's say your grandma goes to fill a prescription. It might be less for her to pay out of pocket for that drug and not use her insurance, but she won't know that. They can't tell your grandma that. They're under a gag order. They have to charge her copay, even though her copay might be more than the drug cost itself. Meanwhile, the pharmacy makes less, the PBM makes more, grandma pays more, and ultimately, big insurance, the insurance company and the PBM, who are oftentimes one and the same, ultimately are making bank off of that drug that could have just cost grandma $5. So that happens all the time because of PBMs. Recently, they have sued the U.S. government because the U.S. government created or tried to propose a rule that states that they have to be, because of their opaque pricing policies, they said you have to be transparent and tell customers what the net price is. So you have to tell us we have to know what the net price is, what the real price is, and what your rebate is. and they've sued and they've pushed back on that proposed rule because, among other reasons that they listed, the one I thought that was the cutest is they thought it would just be confusing. Like, we don't want to confuse grandma, right? If she sees these price, like all these numbers, like if she sees like the numbers like 5 and 2 and 30 and 20, like, oh, we don't want to confuse grandma with basic math. So yeah, they're suing. That's pretty funny. And a lot of states, and I want to look more into this. I, for example, don't even know where my own state stands on this, but West Virginia, they felt like they were being defrauded by the PBM. So they ended up firing them entirely. They just brought everything in house. They said, we're going to circumvent this whole system. And they saved $22 million on drug costs in their first 12 months, not using the PBMs, firing their PBMs. And so you can just Google or DuckDuckGo, as I like to do, states firing PBMs, and look more into that issue. I'll post something about it in the show notes too, so you can look it up. So I mentioned that over the next 10 years, we're looking at a decrease in primary care providers. What we're simultaneously looking at over the next 10 years is an increase of population over the age of 65. So pretty soon, we will have more people in this country over the age of 65 than under the age of 17. And that's important because we're going to have more of our population is aging. So if your grandma is on 5 medications, but these costs keep going up because of these just corrupt systems and practices, if grandma's getting price gouged and her benefits run out, she's used all of her benefits and exhausted them after 8 months, there's anecdote after anecdote that you will hear if you listen of people in these exact situations where, my mom had to go off her psych meds and now she's having mental breakdowns, or they had to decrease the dose on this because it was getting too expensive, or because insurance wouldn't cover it anymore. Story after story after story. And our aging population, our elderly population, is going to be in a position to be screwed. Fewer primary care providers, increasing health costs. Meanwhile, quarterly earnings are okay though, so we're fine. Don't worry. As long as quarterly earnings are looking good for the 3 bigs, Big Pharma, Big Medical, and Big Insurance. Yeah, the one I'm talking about right now. So meanwhile, just over here, I promised that I would pick on drug companies a little bit more. They are continuing to just remarket the same drugs to maintain their profit margins. So just a throwback. This episode's going to be a little bit longer. I apologize. But I think the OxyContin's like, come on, we're going to talk about drugs, right? Stay for a minute. I'll talk to you about drugs. So Oxy. So opioids, it was originally prescribed if you go back to the Wayback Machine for like cancer patients, people in severe pain. So the company who manufactured, Purdue Pharma, who manufactured OxyContin, they originally, before that whole debacle, they were responsible for the Valium epidemic. So if you remember, they told people Valium was non-addictive. They said it's for all kinds of pain, right? So, you got a migraine, you got, an injury, and you have shoulder pain, just, take this non-addictive Valium. They ended up getting investigated by the federal government, and they had to pay a penalty, which was, as always, and this has been the model since then, you make $11 billion, you pay $3 billion in penalties, when you're investigated and have to get called to account for this. And you come out on top every time they come out on top. So their patent on hydrocodone, after this whole Valium debacle, their patent was expiring. And this is what drug companies do. I'm telling you this one specific story because it's a playbook, and this happens over and over and over again. We think, they're innovating. No, they're remarketing the same drugs over and over. It's happening right now with the booster, and there are problems with it for many reasons that I'll get to. But their patent was expiring. They expire after 10 years. So they play this shell game where they just reapply for the patent under a new indication, or they'll have a different combination of ingredients, or they'll add something to it or something. And why that's important to know is when they do that, so in the case of OxyContin, they just added oxy to it. They said, we'll add oxy to our patented delivery system. Problem was, it's 10 times more addictive than hydrocodone. But, in theory, they said because of our patented delivery system that, layers out the drug, so it's a slow release rather than all of that milligram dose all at once. It's not addictive. It's actually less addictive, you guys. But they remarket these drugs, and all they have to do is they have to say the indication is different, so it's for this now. Or they have to say, oh, we added we added an ingredient to it. When they do that, every single time they do it, and this is the same with the COVID booster right now, they do not have to do human trials. They have to do no new safety studies or human trials. They can just kind of piggyback on the old research, which is a problem because we're talking about just, I mean, to me, I don't even know chemistry, but basic chemistry, like it's a different mix of ingredients oftentimes. Like in this Omicron booster, it's a different structure, it's a different chemical makeup of a product. In the case of OxyContin, they didn't have to do safety studies, no new human trials. They just said this is safe and effective because, the product where we originally applied for the patent 10 years ago was deemed by us to be safe and effective. So no new human trials. By the way, I just think it's funny that in this Omicron booster situation, I saw a story the other day that was like, California was saying, we're so thankful that our population is so highly vaccinated because COVID deaths are rising. And I was like, rubbing my eyes, like, am I reading this right? Clearly my vision is impaired right now because I thought that at the end of the day, like we lost the whole it prevents infection. We lost it prevents spreading infection. We lost, like, now people are still saying like we're vaccinating and we're continuing to boost because it prevents severe illness and death. And California's over here saying, whew, COVID deaths are on the rise. It's a good thing that most of our population is vaccinated. Dude, what kind of backwards logic is that? I don't even know. Anyway, I digress a lot. So yeah, Purdue combined their originally patented delivery tech system with Oxy. It was 10 times more addictive. They said it was less. They didn't have to do any new safety studies or human trials. By the way, this is also important because when a lot of drugs that are remarketed are marketed to a whole other population. You might be marketing like a dementia drug, and then when you reapply for the patent, say that the use of this new one is going to be for pregnant women. That's a different population. How do we know like that safety studies for this population for this use are going to be, at a potentially different dose to an entirely different population? How do we know it's going to be safe and effective for that population? We don't. But we'll test a few rats maybe, if you're lucky. So during this time, Purdue Pharma, this is a true story. This is all documented. I have researched this just to double check that I'm not like running with some wild like wives' tale. So they met with the head of the FDA after hours at a hotel. And the head of the FDA at the time helped them draft their application and helped push it through. So they ended up getting it approved, OxyContin, and that is, and they put in the label that it's less likely to be addictive and abusive. And then they thrust that into the marketplace. Mind you, and we could go into a whole other episode. I may have my friend who was a former drug sales rep on, but meanwhile, they gave that to sales reps, said push this drug to physicians with their, $17,000 a month expense accounts. And they, went out with this, we're on a mission to stop pain. Like, we're going to eradicate pain. Nobody has to be in pain. Pain is inhumane. And here's this new drug that's going to do it. Whatever the pain, like prescribe OxyContin. Side note, that FDA director ended up going to work for Purdue Pharma 18 months later, making a cushy salary. Just like, spoiler alert, most FDA directors do. So 12 out of the last 15 specifically. After they've set regulations for those industries, they go to work for Big Pharma or Big Medical and cushy jobs. Incestuous. Okay, so when people started getting addicted, then Purdue just pivoted / leaned in more, and they launched a higher milligram pill because their argument was people are getting pseudo addicted, and they called it, get this, you guys, breakthrough pain. Does that sound familiar to anybody? It's just breakthrough infections. It's rare. And it was like, some experience breakthrough pain because they're actually not addicted to the medication because it's non-addictive, promise. And they're just addicted to the relief it's providing. So really the only solution is, they're still in pain. They're having breakthrough pain. They need more pain meds. So they launched a higher milligram pill. Knowing what we know now about the opioid epidemic and what havoc it's wreaked on our country, this is like alarming to hear. And it's like, what were they living in, like Banana Republic? This is still the Banana Republic we operate within, you guys. Nothing has changed. It's just Oxy's been outed, opioids have been outed, and now we're still in this broken system, and companies are doing things the same way. Um, the only difference is now we have a monitoring system for when it comes to opioids specifically. And by the way, one thing that's gotten missed in the opioid epidemic and the havoc that it's wreaked on us is, as I've talked about opioid deaths, nobody's talking about heroin and fentanyl deaths in that number. We are talking about it, but not in the context of the opioid crisis. Because once the monitoring system was introduced and those people couldn't, readily access pill mills or black market or whatever, they couldn't access opioids, they got heroin and fentanyl. And it's just really sad. So Purdue Pharma paid $3 billion in penalties, which sounds like a lot of money. It is a lot of money. They ended up paying $3 billion for it. But they made $12 billion, so quarterly earnings are still okay, you guys. So we're still doing fine. We're still doing fine in our healthcare system in the United States, because as long as quarterly earnings are great, we're all good. I'm going to skip over that little story. Yeah, really all I'm getting at, I think if there's one takeaway that I have from all of this that I would impart or suggest to you, it's your life. I'm not a scientist or a doctor or a professional of any kind in this space. I'm just like a recovering alcoholic who stays at home with their kids most of the time and happens to be interested in, I don't know, being healthy. I heard this analogy and I love it, and it's about a hammer. So if you want to know about a hammer, it's true though. If you want to know about a hammer, if you want to know everything about it, you don't go to the person wielding the hammer. You go to the person who invented the hammer. And I think that analogy applies perfectly here, because I think that I love physicians and nurses and even salespeople. Like, I love the people. I think that they're most of the time trying to do good with the cards that they're dealt. I really do. But I think that what's become clear to me in this process of uncovering a lot of information about how our systems work in this country is they don't know what they don't know, okay? They have blind spots too. They're human, and they're operating in a system too, okay? They're arguably operating way more within that system than any of us, because ultimately their livelihood is tied to it. So they're doing the best that they can. Let's give them the benefit of the doubt. But if you want information on how something works on a new treatment, if you want to know about peptides or IV therapies or ozone treatment or chiropractics or whatever, I remember I asked the pediatrician once when Jocelyn, our newborn at the time, couldn't poop and she was colicky. And I was like, what do you think about taking her to the chiropractor? A lot of friends have recommended that. And it felt like the right thing to do for me. And I happened to know a chiropractor that I trust more than anything, who like adjusted his babies right out of the womb, basically. And they're like, we can't recommend that. And I was like, so you're not recommending? Well, I'm not recommending it. It's just like, I can't recommend that. And so, y'all, I turned and I researched it for myself, because the implication was like, we can't. And that's a legitimate answer. I'm not saying that like they were doing anything wrong, but I'm saying like, if you want to know about something, then go research it for yourself. Go to the thought leader. There's a saying in this industry that I've learned that's like, in science, innovation happens one funeral at a time, which is super depressing, but it's true. That today's thought leaders do not want the up and coming thought leaders like to have the biggest voice. They want to maintain like their big innovations and reveals that were like the big news of their day. And so innovation, it actually, even though like there are some up and coming technologies and interventions and treatments and some really cool things happening in the world of science, it's not making it into the mainstream, and certainly not into the system that is our, healthcare system as run by big medical, big pharma, and big insurance. It's not making it into the system for a couple of decades. So we're really behind, and I think the results speak for themselves in that regard. So, what I wrote is they're mostly well-meaning, but they're working in a system that forces them to, first of all, rush if they want to make any money. They operate in compliance with insurance companies. They're facing an uphill battle when it comes to that. and which drug reps they have the best relationships with. And I respect like loyalty and trusting like your people that you work with, but a lot of the drugs that are pushed to us are because it's a product of who has the best relationships with their, which pharmaceutical rep they're working with. They say, and this is also an open secret, that what you learn in med school is going to be irrelevant, or what's the term? Not ubiquitous, the opposite of that. Obsolete, there's the word, in about 2 years. And these physicians, they are doing continuing education, but usually it's within the field or the set of skills, the skill set that they already operate within. So it's kind of brushing up on current things that they're doing. So you're naive if you think that they're reading all of these white papers. So, and I know somebody, I know that somebody just heard that and they were like, my doctor reads blah, 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 blah. Keep your doctor then. That sounds great. That sounds like a great doctor. But by and large, from what I've learned, it doesn't sound like physicians are like pursuing, like casting the net wide and trying to like be abreast of all kinds of the latest information. And if they are, it's probably depressing to them because they're like, I know that none of my patients will ever be able to take advantage of this because I'm working in an insurance model and insurance won't pay for any of this. Why would I spend all of my time and resources getting educated in these things that I can't even give to my patients because they won't get covered? It's just an uphill battle. So, yeah, I think that's enough about hammers. Thanks for bearing with me today for a longer episode. See you next time.